I'm well. Thank you for asking. Let me give you some housekeeping stuff, some disclosures, and then we'll talk about more interesting matters. Thank you once again for agreeing to spend some time with me. You already know I'm Stephanie, and I work for an independent market research agency called Ipsos Healthcare. We've been retained by a pharmaceutical company to speak with a variety of clinicians to gain a better understanding of how patients who experience constipation as a complication of neuropathic disease present and are treated. This is not a promotional conversation in any way, strictly for market research purposes, and everything you share with me is kept in confidence. I follow some important market research codes of conduct. One of those is that we don't reveal your identity to the client at any point in time, so that's why you are Dr. John today. The familiarity is by design. And you do have the right to refuse to answer questions or to withdraw from this process at any point in time if that suits you. You do need to be aware that we are recording the conversation, and that's so I have a record to refer back to for analytical purposes. Representatives of my organization or the client organization may listen to the recording so that they can hear your comments firsthand. And lastly, I'm sure you know this drill, in the event that you mention an adverse event or a product complaint that you have observed in a specific patient or a specific group of patients with one of my clients' products, I am obligated to report that even if you've already done so. And if that comes up, we'll talk about that process and confidentiality and all that good stuff. So let me just confirm that you're still willing to continue on the basis of that introduction and see if you have any questions for me.
I am willing to continue. I have no questions.
Thank you very much. That was very thorough. All right. Well, let me begin by asking you to tell me a little bit about your practice so I understand where you're coming from today, whether you're solo, multi-specialty, what have you, and a little bit about the kinds of patients you see and the demographics of your community. Sorry about the participation from my dog there.
You may hear my dog soon. But
okay.
I'm a general neurologist practicing in a suburban location for the past 20 years. I am in a multi-specialty group.
Okay.
But my pod has 3 other neurologists in it.
Okay. How many other specialists of different stripes? I mean, is this a big group?
It's a pretty big, it's like, it's probably about a 400 to 500 man group.
Oh, wow. Wow. You said 45 or 4,500? 45.
No, 400 to 500.
Wow. My goodness. Okay. We are in a new day and age, are we not?
We are in a new day. Yeah,
okay.
I wasn't always in this big group, but it's a new day and age. So.
Indeed. Yeah. All right. Well, I'd like to focus first on your patients who have Parkinson's disease. And I'm curious what percentage of them seem to experience constipation as a complication?
Well, I mean, for Parkinson's, constipation is probably one of the most common symptoms, and they even say it often predates the signs of tremor and rigidity. So I would say of my Parkinson's patients, at least 80% have constipation.
Okay. Okay, and often predates the tremor. Okay. Now, are they prepared for this? I mean, has anyone told them that this could be related to the Parkinson's, that it's something they can anticipate developing if it wasn't happening before?
I mean, I don't think they know it. I don't, because I will discuss it with them. But very often they'll say, oh, the medication that you gave me, I hear that a lot, the Sinemet you gave me makes me constipated. And I'm trying to tell them, no, it's not the medications that are making you constipated. It's the Parkinson's disease itself that's making you constipated. So I don't think, I mean, as far as a lay person, Parkinson's and constipation are generally not related in their minds.
And nor has the primary care physician or anyone else told them that they could be related.
Yeah. Exactly. I'm not sure how much it's in their minds even,
So how severe does it seem to be, if that's the right word to describe it?
Well, I mean, I think it runs the gamut from mild constipation, where they may, need to be on a stool softener, take a Mylanta or something every now and then, to more severe constipation where it really is bothersome and impacts their life.
Okay. Yeah. Where does it rank or rate in terms of all the other things these folks are having to deal with their Parkinson's? How big a deal is it?
I would say I think it's up in the top 5. I think it is. You know, I mean, their motor function, their walking is usually number 1, but constipation is not too far behind, particularly in more severe cases where it becomes an issue.
You mean more severe cases of constipation or more severe cases of Parkinson's?
No,
okay.
Constipation.
You know, you said something I want to go back to, that that the constipation often predates the tremor. Is that to say that, you know, chronic idiopathic constipation looms large in the population overall, or is it something that's related to the pathogenesis of Parkinson's? But
I think it's the pathogenesis of Parkinson's. So, you know,
okay.
before you have Parkinson's, you know, these neurons that are degenerating have been going for years. Before you show any signs of Parkinson's, you've already lost 50 to 75% of the brain cells that make dopamine already before you even show a sign of it. So you know, the constipation they may find before they have the more symptoms are just part of the degeneration of their nervous system.
Mm-hmm. Okay.
But they don't have signs of Parkinson's yet.
Mm-hmm. Mm-hmm.
That may be the first sign, kind of.
Do you find that constipation worsens as the Parkinson's advances?
Good question. I would say, I think it's tough. I think some patients, I think generally yes. I'll say generally yes, but it within the individual patient.
Mhm. Mhm. Okay. Yeah. So what you said that you ask about it. I think you told me that you ask about it among the other symptoms. Okay. Tell me how that conversation generally goes. What are you saying, and how do they respond? And when do you say it?
I mean, usually when I first see a patient, I'll say, "Are you constipated?" I mean, sometimes that helps me make the diagnosis in a certain way. You know, just another piece of the puzzle that says, "Oh, they're constipated." Well, that goes with Parkinson's. So I usually ask when I first are working up a patient with Parkinson's, "Are you constipated?"
Okay. Okay. Do you find that they've already possibly discussed it with another healthcare professional, or is this the first?
I mean, I don't think so. And most of them are not. You know, most of them are not discussing with other healthcare professionals. I don't think so.
Okay. Not bringing it up to the primary care or whatever.
You know, if they are, they may. I don't know if they have or not, but it's not a. You know, it's not a primary diagnosis that they're coming to me with.
Mhm. Mhm. Okay. So what do they complain about? I mean, what you mentioned that there's maybe a more mild form and a more severe form. What are the impacts that it does seem to have?
Yeah.
On?
I guess I don't get into. You know, I probably don't get once they. I'm not GI, so it's not like they tell me constipated, and I start getting into too much detail other than I kind of mark yes or no. But I mean, you know, the things they'll complain about, they're constipated, they can't go to the bathroom. It's not every day. They get some stomach upset. They feel tight, you know, in down there. You know, it's kind of a very you know, annoying and upsetting symptom to be constipated.
Mhm. Mhm. Okay. So do you actually categorize it? I mean, in your notes, in the chart, do you say mild or severe?
I usually don't. I usually say they're constipated, yes, no, and then I kind of move on.
Mm-hmm.
Again, just I guess because I'm not GI, so I'm not asking them about consistency of their bowel movements or you know, I may ask about frequency, but I'm not. So I don't. So usually I don't rate it.
Mhm. Okay. Mm-hmm. Yeah, there's I forget what the scale is called, where they actually talk about shape and size and all this stuff. Yeah. Okay. You don't do that scale.
No, because I'm more interested in the Parkinson's and you know, as opposed to I'm interested in the constipation, but it's not my primary focus.
Right. Okay. Do you find that some Parkinson's patients are more likely to have severe constipation than others? I mean, are there other comorbidities or features of their mobility or what have you that might correlate to more problematic constipation?
I mean, I haven't seen it. I haven't noticed any pattern.
Okay.
From anecdotally from my patients, I haven't noticed any pattern.
Okay. So tell me what your treatment approach is. What do you recommend first? Well, how does that trial go? Tell me what you're recommending for these folks.
Well, I mean, first I recommend that they all be on stool softener like Colace. I recommend that they improve the diet, more fiber in the diet, maybe take Metamucil, something along those lines. And that's usually my first line of treatment for the patient. If they worsen, I recommend taking something like a Mylanta or something like that. Something that will help them go to the bathroom a little bit more. And if that doesn't work, then I say, well, you can try an enema, something along those lines. And that doesn't work, I often say, well, maybe we need to have you go see GI.
Okay. Okay. So let me walk through that with you again and ask you a few questions. So first off the bat is the Colace and possibly Metamucil. How long is that trial? How long do you ask them to give that a go before we see?
I usually give it a couple month trial. I say take it, and then when I see you next time, we'll talk about it, see how you're doing.
Okay. Okay. And then you said you might add Mylanta if it worsens, meaning if it doesn't improve or if something else changes.
Well, if it doesn't improve, I should say. Mylanta, milk of magnesia, if it doesn't improve.
Okay. And then is that another, to the next visit, another 2 or 3 months, or how long is that trial?
Right. It is another 2 or 3 months. I mean, I have to admit, I'm probably not, doing it a week to week. So it's another 2 or 3 months till I see them again.
Okay. And then recommend an enema. I guess you're talking like a Fleet, an over-the-counter kind of thing.
Fleet enema, something along those lines.
Okay. So how often do you find you have to end up referring these folks to a GI?
It's usually not that often. I would say of the patients who are constipated, if 80% complain of it somewhat, of those who are really severe, I mean, I think it's only like 10 to 15% are that severe that it becomes a major issue. So, of those, so I would say 10% of patients I may have to refer, or I may say, instead of GI, I may say, why don't you talk to your primary doctor? So some I say GI, some I'll say, this is beyond me at this point. Go talk to your primary doctor.
How do you decide whether to refer to a GI or a PCP? I mean, is there a reason, or is it kind of arbitrary what you're thinking that day?
I think it may be arbitrary. I mean, if I know if they already have a GI doctor, I tell them go see him. If they don't really have one, I may say just go see a PCP, let him look at it. So I don't have a firm rule. I mean, unless they are just like the quality of life is becoming so severe from from the constipation, which I haven't seen that much where it's like the overriding factor, then those I certainly would be if the quality of life is so affected. But if it's affected enough where they're complaining about it a lot, they're not improving, then it is kind of arbitrary of where I go from there.
Okay. If you had another kind of neurological patient, and I don't know what the example would be, but someone who you might suspect has just, your garden variety chronic idiopathic constipation, would that treatment algorithm you walked me through be any different?
I don't think so. I don't think so. I still try to give them what we talked about, the platform stuff, of the medications, and then when I feel that they're not getting better, I can't tell you I go to the heavy duty medications, Amitiz or anything like that. Usually I will defer to the primary doctor or GI doc.
Mm-hmm. So what is it about the heavy-duty meds, as it were, that you're reluctant to prescribe them? I mean, and that's not a challenge. I'm really just trying to understand.
Right.
I mean, I know you're
Right.
not a gastro. I get that. But
Right.
what is it that makes you not feel that you could reach for
Well,
those in your practice?
right, a few reasons. I mean, one is because I don't treat constipation, even though it may be a feature, in this case, neurogenic constipation. But I don't really treat it. Number two, well, I don't know much about the medications. I mean, I know some peripheral stuff, but I'm not getting detailed on these medications. I'm not, so I'm not really, I don't know that much about it, so I'm not comfortable as much with these medications.
Mm-hmm.
And probably the third thing, honestly, I have a feeling that there's going to be a huge hassle prescribing some of these heavier medications, meaning getting prior authorizations. And, as a neurologist, I'm like, do I want to be getting prior authorizations for medications I don't normally prescribe?
Mm-hmm. Mm-hmm. Okay. So it's nothing it's specific to the medication. It's more sort of the context of your familiarity and your clinical background.
That is correct.
Mm-hmm. Mm-hmm. Okay. If the medication was detailed to you, would that be enough to make a difference, especially if it had been perhaps studied in patients with neurogenic disease?
If the medication was indicated, I have to say, details actually do increase use of the medication. If I had someone coming in, I think I probably would be more comfortable and would consider using it more often.
Mm-hmm. Mm-hmm. Okay. And I'm going to assume that a drug like Linzess or Movantik maybe falls into the same category of you're just not your thing.
Right. Those other medications do fall in the category, and it would be the same kind of reasoning.
Mm-hmm. Mm-hmm. Okay. Well, let's turn our attention now to a different type of patient that you see in the practice, those with spinal cord injury. I'm curious how often you run into constipation with these folks.
I don't, I do have spinal cord injury patients. I doesn't, I guess I don't ask about it as much, and I don't see it as much. So I've had a few that complain about it, but I don't, I guess I don't focus on it as much.
So help me understand that. I mean, you are asking the Parkinson's folks, but it's not part of your ritual, if you will. Your history taking and whatnot with these people. Why is that?
I guess one is when I do have a spinal cord injury patients, these are usually patients with older spinal cord injuries. So it's not like I'm coming on the scene and diagnosing a spinal cord injury, and unless it's due to I say in the office, unless it's a spinal cord injury due to like a chronic cord compression due to spondylosis or something like that, which does happen not infrequently. But these patients I haven't found been complaining about constipation. So the patients who've had, say, a traumatic spinal cord injury, I'm not seeing them acutely, and they kind of like plug in the system where I'm not really, they're not complaining to me about it, so I probably don't ask about it too much, to tell you the truth.
Okay, so I want to make sure I understand when you said older spinal cord injuries. It sounds like you're talking more like, the person who, I think you said like disc compression, or maybe they've had a back surgery or something, not the folks necessarily who are wheelchair bound. I mean, is that kind of the distinction?
No, not even. I mean, I guess you could, why do they have spinal cord compression? Is it due to an acute traumatic injury, or is it due to a more chronic process due to a disc and arthritic changes? So, I'll see in the office. I'll see patients more often who have the cord compression due to arthritic injuries or arthritic changes or a disc. Those patients don't seem to be complaining about constipation. I do ask about bowel or bladder, particularly about incontinence, where I see incontinence sometimes, but I haven't seen constipation as a major feature of these patients.
I'm hoping you can educate me a little bit here. What's the correct way to talk about this range of spinal cord injuries? I mean, would we say mild? Would we say partial?
Yeah,
I heard you say traumatic. I mean, these are all useful terms for my client to understand.
Right. I mean, I'm not sure if I mean, you could break it up into if it's traumatic or not traumatic. A lot of times you could break it up into cord level, where the spinal cord injury is. You know, you hear, a C6, a C8, a T2, so that may be helpful. For neurologists, it's helpful to visualize what may be wrong with the patient. I don't say spinal cord injury, wheelchair bound, not wheelchair, I don't say that. But if you tell a neurologist where the level of injury is, they kind of know what may be affected on the patient. So, you can say acute versus chronic. That's what if there is some kind of definitive scale, I don't use it. That's kind of what I have in my mind.
Okay. No, and I'm not testing you. I'm not aware of anyone. I'm really looking for you to educate me. So I heard you say as well that incontinence is often a more pronounced issue than constipation. Is the incontinence specific or more prevalent in a particular type of spinal cord injury patient?
No. Anywhere in the spinal cord above, S2, S4, and above, yeah, you can get it. So it's not specific for any one level.
Okay. Let's talk about another type of patient, your patients with multiple sclerosis. Tell me about constipation in this population.
Again, I don't, I see much more urinary problems, urinary frequency, urinary retention, incontinence, but I don't see a ton. I've had patients, I guess, with MS complain of constipation, but they certainly don't volunteer bowel changes as opposed to bladder changes, which is very frequent and very common in MS patients.
And it's not something you're proactively asking about and probing on.
Constipation. I mean, I ask. No, I guess not. I say I may say any change in bowel bladder, but you'll say how. Usually, I focus on the urination. I say how are you urinating? Maybe I'll start asking about their constipation, about their bowel habits, but they don't complain about it. They complain. They'll tell me anything, and they don't complain about constipation so much.
If you did run into an MS patient or a person with a spinal cord injury and they were complaining, what would be different in terms of that algorithm you talked through with Parkinson's?
Not a ton. I mean, certainly for the more acute spinal cord injury patients, you don't want them being too constipated and straining too much. That can lead to some other issues, autonomic dysfunction, where they could actually pass out and have fluctuations in heart rate and sweating and blood pressure. That's more of an acute spinal cord injury usually. But as far as, say, a chronic spinal cord injury or an MS patient, I would follow the same algorithm. Trying the platform, coalesce and fiber. That doesn't work. Moving more to Mylanta or milk of magnesia, and then do they need to be on an enema or something along those lines?
So even with this acute spinal cord injury patient who doesn't get relief after that whole platform plus, would you be any more likely to prescribe an Amitiza or something in that population, or we're still talking about referring?
I would probably, refer. But I guess I would in my mind, I would, again, probably refer, but I guess I'd be a little bit, in a spinal cord injury patient, I would be perhaps more proactive, just because of what I talked about before.
Proactive in referring them or in
No,
pursuing the platform at all?
maybe more proactive in both. Referring and where I say, oh, you can't get in for a while, maybe we'll try Amitiza, something along those lines.
So how many patients would you say you have written Amitiza? I'm trying to get, how prevalent is this situation?
Well, I think the only patients I've ever written it for were patients who were already on it, and I just said, all right, I'll give you the medication. So how many starts? I don't think I've actually started on any medication, any patient on it.
Mm-hmm. Mm-hmm. With your spinal cord injury patients, how common is it for them to be taking an opioid?
I would say in my spinal cord injury patients, again, I would say 40%, 35, 40%.
Okay. Okay. And yet they're not really complaining about constipation that might be linked to the opioid.
Some of them could. I mean, if you're on an opioid and you're complaining of constipation, you certainly have to think, could that be the reason why?
Mm-hmm.
So, I would definitely think more that would be the cause as opposed to the spinal cord injury even.
Mm-hmm. Mm-hmm. So, well, I know you said that they're not really talking about it. Only a very few complain. How often are you hearing it as a complaint where you might have to kind of parse that out in your mind? Could it be opioid-induced?
Again, I'm just not hearing that much about it. And maybe because they've already talked. I don't give them the opioid. Maybe because I'm not the one prescribing the opioid. I don't prescribe opioids to patients. So maybe they're already talking about it with their doctor who's prescribing it. So I kind of leave it alone.
So who do you think is prescribing? I mean, does the patient follow up with you and say, okay, thanks for giving me the name of that gastroenterologist. Here's what happened.
Mm-hmm.
Who's writing the bulk of the Amitiza and the Linzess prescription?
Oh, I think I would assume the GI doctors, I believe. I don't know about if the pain management guys are. I don't know.
Mm-hmm. Mm-hmm. Okay. I'm just making a note. So I'm curious whether you're aware of any new medications in development for constipation, recognizing you're not a gastroenterologist, but have you heard anything about treatments for constipation in these patients with neurogenic diseases?
I have not. I mean, the answer is no. I don't know of any. I do see, again, with Movantik, I've seen, I think, 1,000 commercials from Movantik on TV, but, that's not for me being a doctor. So our company is trying to get in the market for neurogenic constipation. I'm sure they are. They could get more indications. That always means more sales and more money for them. So it wouldn't be shocking if one of these medications try to get that indication.
Mm-hmm. Well, it did sound like the burden of disease, if you will, was pretty high within the Parkinson's population. If a product were specifically studied in Parkinson's, I mean, I get the profit motive and all that, but would there be, a good clinical rationale and advantage and benefit there in your mind?
I think if you had a medication as a proof of Parkinsonian constipation that was marketed to neurologists, drug reps coming in, maybe, a local lecture by some expert, I think neurologists would feel more comfortable prescribing it.
Mm-hmm. You among them?
Me among them, yes.
Mm-hmm. Mm-hmm. Okay. Again, I'm not trying to test you, and I'm already at the limits of my command of this area. I'm curious whether you would have a preference or a point of view about a prosecretory mechanism of action versus a prokinetic mechanism of action. Would that matter, knowing what you know about Parkinson's?
Excellent question, of which I have no idea.
Okay, that's fair enough.
I guess, actually, and I don't know the answer to this, but in my mind, if someone said, for Parkinson's, would you want prosecretory or prokinetic? Well, since Parkinson's, one reason why they have constipation is everything is slowed in Parkinson's, including the gut. The gut is slowed. So if you had a prokinetic medication, that would, that seems to me that may be of benefit, Now, clinically, what does that mean? I can't tell you, but yeah, if I had to choose one, it would seem to me ProConnect would be better.
Mm-hmm. Mm-hmm. Are there any downsides to the prosecretory or any, anything I need to be aware of in the Parkinson's population with that mechanism of action?
Not that I would be aware of.
Mm-hmm. Mm-hmm. Okay. I think, let me try and understand. I'm not an expert in Parkinson's at all. When you say everything is slowed, explain that a little more for me.
Well,
what kind
Parkinson's, classically, Parkinson's is a motor disorder due to lack of dopamine, and certainly you have motor function where you're slowing. You have the tremor, but everything else is slowing down. Your movements are slowed down. Your walking is slowed down. Your facial movements are slowed down. But also, the disease occurs and affects non-motor problems, where you swallow less. Your gut is affected by Parkinson's, which is why people get constipation. So I guess the gut doesn't specifically besides slowing down the gut. I guess the movements of the gut aren't as quick or fast or as often as they had been in the past. You swallow less with Parkinson's, which is why they drool. So, like I said, that's a non-motor function of Parkinson's that the gut is affected also.
Okay. So I'm going to bring up two slides for you to look at. Just, read them at your own pace. Let me know when you're ready for me to advance from the first to the second, and then we'll talk a little bit about them. Here comes number one.
All right. Product X. Okay.
And slide 2.
Okay. All right.
So, I'm sorry, you're still reading. My apologies.
No, I read. I just know benchmark, nausea 10 to 20%. That means it causes 10 to 20% people have nausea and diarrhea. Is that what this? I know what the benchmark means.
Low levels.
It says low levels of nausea, diarrhea.
The benchmark.
With no drug in less than 10%. But then it says benchmark, nausea 10 to 20%.
I think I'm going to assume that the benchmark means from the standard of care, like an Amitiza or a Linzess. These are the incidences of nausea and whatnot from their label, and they're saying Product X would be below those benchmarks.
Okay. All right. Fair enough. Okay, I'm done.
Okay. What's your overall reaction to what you see here?
Well, it sounds good. Seems to be efficacious, and it seems to be fairly well tolerated, particularly if it's less than 10% as compared to the benchmarks. I guess we'd be concerned about stuff like diarrhea and fecal incontinence for sure. But if the quality of life is improved, it sounds like this is a fairly good drug.
Okay. Let me poke on a couple of details here because, let's assume now that it is studied and approved in this population as it says, and that you are being detailed on it. You went to your annual professional meeting and there were discussions about it and the thought leaders are talking about it. So all of these reasons that would create comfort in prescribing for you.
Yes.
I'm curious what difference it might make if instead of QD dosing, I'm just making this up, let's say it's BID instead. How does that change your level of interest or impact your level of interest?
I don't think much. BID is not, once a day is always better, but BID is not intolerable, particularly in patients with Parkinson's who are used to taking medications 3, 4, sometimes 5 times a day. So
Mm-hmm.
I don't think it has a meaningful impact.
Mm-hmm. Mm-hmm. Okay. Now, what if it were not oral? What if instead it's a sub-Q injection?
Well, that changes everything.
Okay.
And I think you're going to have very few patients will want to take it.
How come? If they're taking all this other stuff and
Well, but those aren't injections. No, patients don't want to take injections. We already have an injectable Parkinsonian medication called Apokyn, and for patients who have freezing episodes, and it is extremely difficult to get patients to want to take it. Again, Parkinson's patients in particular are very elderly. Their caretakers are very elderly, and injection medication gets to be very difficult.
Now, with that one that patients are resisting taking, is that a sub-Q or is that an infusion?
It's a sub-Q.
Okay. Okay. So this just adds to the burden big time, it sounds like. Yeah.
Most patients would not want injections, I do not believe.
Okay. What are some of the endpoints that would be important to you as you're sort of, gaining comfort with this medication? What would you want to see in the results of the trials?
Right. I mean, being said that I don't know what constipation endpoints often are. I guess how many bowel movements they're having in a week, say. They say here time to first bowel movement. I guess that I think that may be important, and I think the quality of life would be important too. So, but I don't know of any. I'm not familiar with constipation drug trials, so I don't know if there are other things I should be looking at.
Okay. So how might you see yourself using this? If all of those conditions were there, studied in this population, approved, let's assume it's been on the market 6 months, so I'm not going to ask you to be an early adopter necessarily. How would you see yourself using something like this?
I think I think if this was an oral medication approved and indicated for Parkinson's disease constipation, I think I would absolutely consider using it on some of my more difficult to treat patients.
Okay, and how would you assess that more difficult to treat?
Ones that went through the protocol that I gave you that didn't improve on it, and there's no other obvious GI signs or issues that I'm concerned about. Severe abdominal pain, certainly no elevation of liver function tests or anything along those lines. So those are the kind of patients who I would tend to try using it in.
Okay. Let's see. And so after you've tried the enema routine, which sounded like that was kind of the end of the line, rather than referring, you might give this a try.
That is correct. That is correct.
Now, I know you said you're not seeing a lot of spinal cord injury patients or MS patients who are complaining of constipation. If this drug were studied in those disease categories as well and were indicated for use in patients like those, how do you think that might change, if at all, how you approach patients and talk about the possibility of constipation? I mean, would it make a difference to have an agent specifically indicated?
If you had an agent that was approved for MS constipation, which again, I don't think it's a huge issue, or you had a medication approved specifically for spinal cord injury constipation, then I think I would talk about it more and bring it up more and ask about it more.
Okay. What have I not asked you that you think would be helpful for my client to understand in this area? Anything else we should touch on before I let you go?
No, I mean, again, I think a lot of these, I think with a lot of medications, familiarity is important, and we certainly, as a neurologist, I can't see myself using a drug that's going to require prior authorization, step edits, that are not even indicated for what I'm treating.
Mm-hmm.
So, they may be in for constipation, but not for, Movantik for opioid constipation. So, so I can't see myself using it off-label on a subject such as constipation that I'm not even treating normally as a neurologist.
Mm-hmm. Mm-hmm.
So, I don't think, so basically, the important point would be if you get an indication and they promote it, then we'd be more comfortable using it.
Mm-hmm. Very good. All right. I heard you. Thank you. Appreciate you spending some time with me this evening.
Okay, you're welcome.
Bye-bye now.
Okay, you take care now.